Welcome to another episode of the AUA University Podcast. I'm Dr. Mark Gonzalgo, Professor of Urology at the University of Miami and Chair of the AUA Office of Education. Today's episode focuses on the early detection of prostate cancer. This is a space where we continue to balance curative intent with the risks of overdiagnosis and overtreatment. With advances in biomarkers, imaging, and biopsy strategies, the way we approach early detection is becoming increasingly nuanced, data-driven, and personalized. Our goal today is to walk through how clinicians can thoughtfully integrate these tools into practice, highlighting not just what's new, but what's practical and actionable. I'm joined today by Dr. Simpa Salami, a urologic oncologist and associate professor at the University of Michigan. Dr. Salami is a nationally recognized surgeon scientist whose work focuses on developing novel biomarkers for early detection, risk stratification, and treatment selection in urologic cancers. Simpa, welcome. It's great to have you with us.
Thanks, Dr. Gonzalgo. It's a privilege to be with you today.
Let's start at the foundation. Why early detection still matters? And taking a step back, Simpa, why is screening and early detection of prostate cancer still so important today?
First of all, prostate cancer remains one of the most common cancers affecting men. And early detection is very important because when you detect a cancer early, you have the opportunity to be able to intervene before metastasis occurs. And in general, in most cancers, cancers would not kill unless you have metastasis. So if you're able to detect it and intervene before metastasis, happen, you'll be able to reduce mortality. And that's why screening and early detection of prostate cancer is still very important. But of course, I recognize that there's quite a bit of controversy surrounding, screening for prostate cancer because of issues associated with over-detection, over-diagnosis, and then the harms associated with treatment.
Yeah, and that's something I mentioned in the intro. How do you frame that balance, right, between what I mentioned was curative intent or benefit from detecting a cancer so early and the potential harm or potential side effects of any treatment that might be involved in? And what does that shared decision-making look like in real practice?
Yeah, so I think it's important to identify those who are most likely to benefit from screening and early detection. And in those patients, one can argue that the benefits may outweigh the harm associated with screening and early detection. And then for those who are likely to benefit, there's no point offering screening, if you will. And so having an appropriate discussion with the patient and going over the benefits of screening as well as the harms associated with screening, and then allowing the patient to make an informed decision, I think is really critical. That's a better approach than a one size fit all, like offering screening for every single patient.
That's a great segue into the next section where we can begin to talk about things that may help to improve how a shared decision-making conversation can take place between providers like ourselves and our patients. And this is really going into that section of biomarkers, right? We have so many new tests that are out there. But let's start with PSA, right? Which still remains the most widely used standard. How should we be thinking about PSA today?
Yeah, PSA is still, as you mentioned, Mark, is still the most widely used oncologic biomarker in the world. And despite some of the challenges associated with PSA, poor specificity in certain situations, I think it's still a great biomarker if used, appropriately. We need to understand that although PSA is prostate specific, it is not prostate cancer specific. PSA can be elevated in benign conditions such as like transient, irritation or inflammation, even without symptoms. It can also be elevated in benign enlargement of the prostate, which as men grow, older, prostate, size can increase. So it's important that we interpret PSA appropriately. And the American Urology Association has provided a number of guideline statements on how to appropriately use PSA that should guide clinicians in offering appropriate screening and early detection program.
Great. All right. So here's the real question I think that a lot of our listeners are going to want to learn a bit more about. Where did those adjunctive biomarkers fit in, right? When should clinicians consider using them and when not? I mean, there are so many out there, whether it's serum-based or urine-based, some tissue-based. What are your thoughts on, again, where these fit in and when we should consider using them?
Yes, we are blessed to have a plethora of biomarkers that can be used to supplement the performance of PSA. As you mentioned, in serum, we have a number of tests, in urine-based tests, and we have one tissue-based test that can be used for identifying patients for biopsy. I think the first statement I'd like to make is that most of these biomarkers tend to have very similar performance in their ability to detect high-grade prostate cancer, grade group 2 or higher. And when you use these biomarkers at the threshold that's been provided by the various companies, you miss a small proportion of high-grade prostate cancer. And the other thing I'd like to mention is the fact that they should not be used reflexively, meaning you get a PSA blood test and then the PSA is elevated. There's no reason to automatically just get a biomarker test. I think we have to identify how it could be useful. And in general, these biomarkers should be used if it would alter or change management decision. For example, if I get a patient with an elevated PSA, let's say a 50-year-old guy with a PSA of 5, and I repeat the PSA test and it's still in that range 5, that is high for that patient. A biomarker is not going to change what I do. I'm going to offer that patient a biopsy regardless. So there'll be no need to offer a biomarker in that scenario. There are situations where I would offer a biomarker. For example, let's say you have a patient who has a benign biopsy. The MRI shows no lesion. PSA density is elevated, let's say 0.4. And if I subject that kind of patient to repeat biopsy, I want to get a biomarker test just to make sure that this patient does have a risk of high-grade prostate cancer before I repeat the biopsy.
That's great. And I was going to focus in on trying to pick your brain about your decision tree making before proceeding to biopsy. And I think you answered my question before I was able to ask it. And I think one of the things you mentioned as well, which is a key theme, is that it's selective, not reflexive, right? In terms of using these types of biomarkers, whether they're serum or urine based.
Yeah, you're absolutely correct. I think that's the word. We have to use it selectively in conditions where patients are likely to benefit from its use.
Now, Simpa, imaging has really transformed this space. Okay. How do you currently incorporate MRI into early detection?
My practice, I get MRI pretty much in every patient undergoing evaluation for elevated PSA. I sort of use it, reflexively. I practice in a setting where we have high quality MRI, but I recognize that the AUA guidelines recommend that using MRI in the initial biopsy setting is considered, optional. Again, just because of some of the limitations when it comes to getting high quality MRI or having radiologists with expertise within the MRI because of the variability in the interpretation of MRI and then performance of MRI in potentially poor resource setting. But I practice in a center where we have high quality MRI and good radiologists interpreting the MRI. So I use MRI in the initial biopsy setting. I also use MRI in the repeat biopsy setting. And the reason is because MRI can help identify a target, and then you target that lesion and it improves our ability to detect high-grade prostate cancer. MRI is not very good in detecting low-grade prostate cancer. That is actually a good thing, right? Because we don't want to detect the low-grade prostate cancer that patients worry about and we don't offer treatment for. So I pretty much use MRI in my evaluation of patients with elevated PSA.
Great. And we recognize the increasing utilization of this imaging modality in helping us guide decision-making for our patients. Obviously, we just talked about biomarkers. Are you using biomarkers in combination with MRI? And if so, how do you do this?
That's a great question, Mark. I think what I would like to see is, using MRI and biomarkers in an integrative manner, determining when to order one test versus the other. But we don't have those kind of studies at this point. How I use biomarkers in conjunction with MRI at this point is I get an MRI first and then make my decision that way Only if I need additional information would I get a biomarker. One example is, let's say I get an MRI and it shows a Pirates 5 lesion. I do a fusion biopsy, it comes back benign, and PSA density is elevated, and I'm still suspicious that this patient has high-grade prostate cancer. Normally, I will repeat, the biopsy. But if I'm confident that I did not miss the lesion at the time of fusion biopsy, I probably will get a biomarker test first before proceeding with a repeat biopsy. So that's one example of how I would integrate a biomarker with MRI.
Okay, great. Thank you for that insight. Hopefully, the listeners will be able to relate to that specific example. Along the lines of the topic of imaging, okay, we know that PSMA PET is being increasingly utilized. Where does PSMA PET fit in, if at all, right now?
At this point, we personally don't use PSMA PET scan in the initial biopsy setting or even repeat biopsy setting. And that's because we don't have great data to support the use of PSMA PET scan in early detection. However, I'm familiar with some data coming out of Europe, particularly and also in Australia, where they have used PSMA PET scan in the setting of equivocal MRI findings like Pirates 3. And data was presented recently at the EAU, the European Association for Urology annual meeting this year, and they demonstrated that using PSMA PET scan can identify high-grade disease in the equivocal, MRI findings. And I said to myself, well, that's an expensive test when you have access to biomarkers that you can use to further risk stratify patients. So at this point, I don't think we have sufficient data to use PSMA PET scan liberally in early detection. I think there's still opportunity to generate additional data to see if it will be useful, at all. I have had maybe 1 or 2 patients where I did order PSMA PET scan, and that is in patients with really, really high PSA. I've had patients with PSA above 30. MRI is negative. You do biopsies a couple of times, and biopsies, came back benign. Just to make sure that I'm not missing anything, I did order PSMA PET scan, and of course, as you would expect, the PSMA PET scan was negative.
Great. Thank you for that insight. I think it's very valuable for us to try to, again, integrate different imaging studies, whether it's MRI or PET, along with biomarkers. So let's talk about biopsy. All right. If you could share for us, what's your current approach to biopsies in 2026?
Biopsies, at this point, we perform transrectal as well as transperineal, but I would say that close to 100% at this point is transperineal, approach. And that is because the risk of infection with transperineal biopsy is close to 0, if not 0. But I recognize that, transrectal and transperineal biopsies are essentially equivalent when it comes to the cancer detection rate. The ability to detect high-grade cancer is very similar from, various studies. But I particularly just use the transperineal approach because it is associated with a lower infection risk. I should mention, though, that the risk of discomfort or pain is higher with transperineal, approach. So recently, as recent as a few months ago, we actually started offering transperineal biopsies under sedation for every patient, unless the patient opts out.
Got it. Yeah, now that was leading into my question about how you do the TP biopsies, right? Whether it's in the OR or an ASC equivalent versus in the clinic, because in talking with a lot of our colleagues across the country, it's varied, right? I mean, even at our own institution, we're primarily doing them, as you mentioned, for patient comfort. A lot of patients are going to, essentially want to be at least sedated or asleep, they'll say, right, for the biopsy. They don't want to be awake for it. So having the ASC option is a very good one for the patients. How do you decide, I guess, on how to do it for those patients? Are you doing these in the clinic and the OR?
Yes, I'm doing them in the clinic and in the ASC. At the ASC, it's really up to the patient if they want to go to sleep or not. But what I've come to realize is that nearly 100% of patients want to go to sleep. And when you think about it, one, the positioning is unnatural for men to be in. And then given the local, analgesia, infiltrating the skin is very, very painful. So the fact that we're able to offer it to patients under sedation, I think has been really, really transformative.
Okay, wonderful. So let's stick along the lines of biopsy right now. Cognitive versus software fusion. Does it matter? Your thoughts on this?
I use software-based fusion in our practice, and that's what most of my partners use as well. But there was a study out of the UK that looked at cognitive versus software-based fusion, and they found that it doesn't matter. They actually looked at who is doing the biopsy. Is it an attendant or a trainee? How much experience do they have? They looked at patients with multiple lesions, patients with a single lesion. They also looked at the Pirate score. They looked at patients under anesthesia versus no anesthesia. And what they found was that there was no difference in the cancer detection rate when you compare cognitive versus software-based fusion. So at this point, I think it really depends on the provider, what they're comfortable doing, and you can get comparative results.
Yeah, and as you mentioned, the literature does support that no significant differences between either of those routes. I want to ask you a question which some of our listeners may be interested in as well, on whether or not you've had experience with or your knowledge about micro ultrasound, right? Because micro ultrasound is one of those tools that people are more commonly using to do, I guess, direct targeted biopsies. Do you have any experience with this or any comments on that?
I personally do not have any experience with this other than looking at or trying them out at various meetings, in exhibits. And I've also seen some of the data. I think, first of all, I have to say that I'm amazed by the picture quality of the ultrasound. And sometimes you can actually see lesions that you can potentially, just directly target. And I think as the technology continues to develop and evolve and becomes widely available, it might be a useful tool to use actually in clinic, right? It's like where you don't have to pre-obtain an MRI and then come back and then try to fuse the MRI with a real-time ultrasound. You can just use a micro, ultrasound. But I think we still need to see more robust data on how microfocus ultrasound compares, head to head with MRI in various settings as we continue to try to implement them in our practice.
Sounds good. And as you mentioned, the imaging modalities continue to get better. Last question on this topic, again, very basic, but wanted to ask it for the sake of the listeners. Do you still perform systematic cores for the biopsies?
I still do. I'll say that in the initial biopsy setting, if there's a lesion, I target the lesion. I obtain generally about 4 cores, and I'll still obtain 12 systematic biopsy cores. In the repeat biopsy setting, in a patient who has had maybe a couple of negative biopsy and then MRI then shows a lesion, I might forego systematic biopsy in that scenario because that patient already had systematic biopsy previously. In the active surveillance setting, if there was a lesion that we're monitoring, I may forego systematic biopsy. But in general, I still try to obtain systematic biopsy if I think it's going to provide additional information.
Great. All right. So looking ahead, Simpa, what excites you most about the future of early detection in prostate cancer?
One is artificial intelligence. We hear a lot about artificial intelligence in really all aspects of our lives, right? I think in medicine, there are various ways that artificial intelligence can also be used to improve the quality of care that we provide for our patients. In the evaluation of patients at risk for prostate cancer, I think one is tools that potentially can take different data points, right? Like demographics, family history, past medical history, potentially even incorporate the overall health of the patient and the projected life expectancy to determine whether a patient should undergo evaluation. And then tools that can look at MRI and eliminate the errors that are associated with the human errors that are associated with interpreting MRI, or potentially identify quantitative measures from MRI images that are not visible to the human eye, and put all of that together, determine the risk that a patient may harbor high-grade prostate cancer, and then also maybe even guide us in our in performing biopsies. I think that is what I'm excited about. I'm looking forward to some of those tools, and people are already working on that. So we look forward to seeing how they are developed and deployed in clinical practice.
Great. Yeah, no, and I agree. AI is touching every part of our lives, not only professionally, but personally as well, and basically in everything we do. As we come to a close, are there any key points you'd like our listeners to remember from this podcast about early detection?
I think the key point is that screening and early detection is really important. We do have to do it well. We have to identify those who are likely to benefit from screening and early detection, and engage in shared decision making, with our patients. And as we do, we can provide the best quality care, available to our patients. And the second point is we have a lot of tools. We need to learn how to incorporate those tools appropriately in our practice, and one size does not fit all.
Dr. Salami, thank you for an outstanding and highly practical discussion. You've done a terrific job walking us through how early detection of prostate cancer has evolved. As you mentioned, from a one-size-fits-all approach, which really isn't the case now, to a much more nuanced, risk-adapted strategy that integrates biomarkers, imaging, and thoughtful biopsy techniques. I think another key takeaway for our listeners is that effective early detection today is less about any single test and more about how we combine tools in a deliberate and patient-centered way. And for clinicians, the challenge, I think, and opportunity is to apply these advances in a way that improves outcomes while minimizing harm. And conversations like this really help clarify how to do that in everyday practice. To our listeners, thank you for joining us. For more educational content, including podcasts, CME courses, and meeting highlights, please visit auanet.org/university. I'm Dr. Mark Gonzalgo, and we look forward to bringing you more conversations that help you stay at the forefront of urologic care. Until next time.